Okay, thank you. Thank you very much. It's a pleasure to resume our activities today, back after a bit of a summer break. I have actually the immense pleasure of inviting Dr. Ali Faisal Saleem, Associate Professor for Infectious Disease and Pediatrician at Aga Khan University Hospital, one of my batchmates as well from Dow Medical University Health Sciences. Ali Faisal Saleem, it's a pleasure to kind of actually have you back again on the program. I think this is your second or third time in the last 4 or 5 years. We started this in 2017, so much actually pleasure to have you on board. And you'll be talking about some interesting topics. So I won't give the topic away. I know people have actually read the flyer anyway. And then we've got another interesting case by one of the trainees, Dr. Salma, who will be presenting after Ali Saleem. Ali Faisal, please go ahead. Thank you very much. Thanks once again.
Thank you, Dr. Mansoor, and thank you very much, Dr. Naseem, for inviting me for this. Yes, that's correct. That's my third time here in the CPD, and I'm sure you'll be able to see my screen with this presentation. Correct me if this is going on. Can you see that screen, Naseem? Or
yeah, we can see the screen. I think are you launching Zoom at the moment, or?
I think your presentation is maybe the one in one of the other tabs. Am I right?
Yeah.
Okay, so let me do it again.
You were able to see your screen. Yes.
You were able to do that before, yes.
Yeah.
All right.
Yeah.
Correct. So let me do it again, and let me know if you can see my screen now.
Yeah. We can. Thank you.
We can see,
Great. Thank you very much, and with due respect, Bismillahirrahmanirrahim. Thank you very much for this kind invitation. What I'm going to talk about is something which is really serious going on in Pakistan. It's the second time we have hit by this serious national disaster. Last time 2010, where we lost a lot of life in 2010, and along with that, a lot of other things happened like catastrophe and others. But this time, the disaster is more humongous in terms of not only the life, but also the livestock, the crops, and a lot of other things which we feel this is really big disaster, and a lot of things going to happen. So I gave this talk recently in one of the course which we have conducted at Aga Khan University, and I was co-partner in that activity, and I'm going to talk about that caring for children during natural disasters. So this is my disclosure statement that I have no financial relationship with property entities and others. This is something which is really important to know about. What are the 5 steps of emergency management? And you can see here, it's coming from mitigation to preparedness, then response and recovery and prevention. Currently in Pakistan, right now we are in the time of response recovery. The blue bar, which is the prevention in this pie, it's actually, we are not yet there. Let's see, but these are 5 emergency management which we usually talk about. So what I'm going to cover today in next 10-15 minutes is children, are they really vulnerable, and what is the risk of vulnerability? What are the special considerations you need to think about when you talk about vulnerability and disaster? These are the nutrition, immunization, and outbreaks, and impact of those natural disasters on children's life. This map, which you can see on the right side of the screen, you can exactly tell you how much damage of the houses happened. It's across the Pakistan, but it started from Khyber Pakhtunkhwa, then Punjab, and a lot of part of the Sindh, and recently the Dadu part is extremely hit by this bad disaster. So I just go back and see what is the definition of vulnerable and what's the definition of susceptibility, and realize that vulnerability is of a person in need of special care, support, or protection because of the age, disability, or risk of abuse or neglect. And here you can clearly see that in any of the natural disaster, it's not the age who limits you for this vulnerability. It's because of your vulnerability to being abused, because of your financial and a lot of other risk factor at that time. However, it's a little bit different from the susceptible, where there is a likely or liable to be influenced or harmed by a particular thing. And in these children or the adults who are actually part of this vulnerability of this high risk situation in Pakistan, they are actually susceptible to a lot of harms. And I'm going to elaborate those harms in my next slides. What are the major concerns? We divide into two major broad categories: infectious disease and non-infectious disease. And you can see here, I really want to talk about this waterborne disease, which are diarrhea or food poisoning, our old friend pneumonia, skin diseases, because they are living in this water, they are living in this damp water, and they are not having their hygiene. So they have a lot of skin diseases. Then there again there is a vaccine preventable diseases, which actually we are low behind of our essential immunization. However, in this part of the time, we are actually far more behind of our routine immunization. When the people scattered and then monsoon happened, the vector-borne disease happened, and Karachi is now, and other part of the Pakistan is now actually in a situation where we are dealing with a lot of dengue and malaria this time. And then again, because not only the humans are actually displaced, the animals also displaced with this disaster. So they're going to happen a lot of bites, and we are seeing a lot of bites of the snake and scorpion in these part of time. These are the infectious disease burden, but you can see that there are a lot of non-infectious disease burden that becomes extreme of weather, allergies, increased risk of vulnerability because of malnutrition, and risk of sexual, mental, and physical violence of these children. So why I said infectious diseases, and the reason behind it, we really need to know it's a waterborne disease. The reason behind is there is no clean, there is no filtered water supply currently happening in any of the natural disaster. People are moving for their food items. The concern about those food is actually that's what is the source of the supply of that food item. So in these areas, or in any of the vulnerable areas, what happened that the food is supplied by an NGO or some other resources, and that is actually mainly of the adult population and not for the pediatric population. And this happened that they don't have a storage capacity, so all these things they store can develop some types of infection because of this, because of the weather calamity, and then they develop a lot of diarrheal illnesses, which can be acute, chronic, or persistent. We see a lot of food poisoning in these areas. Enteric fever is actually endemic in Pakistan and continue to affect the adult and adolescent and children across the Pakistan, particularly in this calamity. And again, viral hepatitis, because like this hepatitis A vaccine is not in the routine immunization, and now with the lack of this clean water supply or filter water supply, there's going to be an outbreak of these hepatitis A and E. I haven't mentioned about the cholera. The reason behind it, anytime you have the cholera, it's a serious risk and emergency. But there's a highly possibility that I cover in this thing, in acute diarrheal illnesses. How to manage diarrhea, and that's what we have to teach to all the people. Remember this acute watery diarrhea, you have to give ORS. You have to give zinc sulfate because it helps the gut to grow. You have to work with the KYB diet. The reason behind this is emulsified, good nutrition diet, which provide good calories in terms of carbohydrates and proteins, and it's digestible. One of the important components in that acute watery diarrhea is clean water supply in these areas, because it's a vicious cycle. If we do not have this clean water, then they develop continuous of acute watery diarrhea. Age-approved feeding practices are really important in these areas, and it has to be trained. It has to be tackled accordingly. If there is a dysentery, it has to be treated with antibiotic, either Cipro or Cefixime. But remember this, in all of my slides, they're going to be static. Means that anytime you have a sick child, you need to refer the child for an inpatient facility for their care. Food poisoning, again, usually self-resolving. You need to give paracetamol or fever for the fever. And if there's acute watery diarrhea, you have to manage accordingly, as my previous slide. Enteric fever, usually this happens in those areas because of this bad water supply. It's usually high-grade fever, not responding to good dose of paracetamol. It has a lot of GI and upper GI non-manifestation. And all these manifestations you can examine and you can elaborate accordingly. The management is, again, you need to give antibiotic along with good paracetamol. If this is multi-drug resistant, it is usually treated with Cefixime. If it is XDR, which is extended drug resistant, you have to consider azithromycin. Remember this, that dysentery is one of the manifestation of salmonella infection. And if there is a deterioration of the clinical condition, you better refer the child to a tertiary facility. In these areas or in these high-risk areas, because of lack of vaccination and others, these children used to develop this pneumonia. The children has to be assessed on the basis of IMNCI, which is Integrated Management of Newborn and Child Care, present and is developed by World Health Organization. One of the most clinical examination is check for the respiratory rate, and again check for the saturation with ACEs available. The most common pathogen again is Streptococcus pneumoniae and Haemophilus influenza type B and non-type level. And again, the management is absolutely very clear that you have to give paracetamol, you have to give first dose of antibiotic, and if you feel this child is sick, you need to refer the child accordingly. In younger children, you need to avoid salbutamol, excuse me. But in the older children, you can give salbutamol for the bronchodilator effect in pneumonias. In all those areas I have just mentioned about vector-borne disease, there are two main vector-borne disease caused by this our friend mosquito. Usually in Pakistan, other part of the endemic region of malaria, it is P. vivax, which is Plasmodium vivax, more common than Plasmodium falciparum. The testing kit is amazing to detect the vivax and falciparum. And again, the drug of choice is always chloroquine. And if there is a consideration that there is a risk of falciparum, or there are children who are not responding to chloroquine, then switch to the combination of these drugs like artemether or lamivudine. Again, work for the paracetamol and refer the child if there is a sickness. Dengue fever, again, is a viral-based disease, and again, it's usually happen post-monsoon. What we really need to consider is just good paracetamol, hydration, and anytime you feel this is dengue fever, it's always better to refer a child for a secondary care or tertiary care facility where the hydration can be maintained, because one of the main risk factor is dehydration, intravascular dehydration in these younger children and adolescents. Again, we are not good in vaccine preventable disease, and our data suggested that we are not performing well. But again, one of the most important components here need to understand that EPI vaccines are safe and effective and accessible. And anytime these medical camps happen, we always try to make sure that there is going to be a small vaccination camp as well. So we should not miss the opportunity of children who really require age-appropriate immunization. And also for older children, it's really important to get a catch-up immunization when they are not vaccinated. Again, I have just mentioned two other vaccines which are really important in times. One of them is cholera, which is free of cost available, and hepatitis A. Again, as I mentioned, that not only humans are displaced, but in these times, the animals were also displayed. So we really need to see that if there is a dog bite, what is the dog or what is the snake type, and you really need to identify it's a one bite or person bitten by multiple animals, or there are events where one animal bite a lot of people at that time. Again, you need to clean this area as soon as possible. If there's a tetanus vaccine available, give a tetanus dose. If there's anti-allergy available, give the anti-allergy, because not all those bites are hazardous to life. However, if there is a consideration of rabies or snake bite or scorpion bite, consider to refer the child as soon as possible where the IVIG facilities are available or a toxin facility available. Again, in all those areas, the healthcare workers who go there, we really need to have a pre vaccination for the rabies, because they may be bitten by these rabid animals in these areas. This is serious about knowing that we already have 40% of our population, younger population, less than 5 years of age, is stunted. However, in these calamity situations or in these disaster, it's going to be a triple burden. So they not only hit by the primary malnutrition, they also hit by secondary malnutrition because of the lack of food supply, because of the lack of healthcare facilities, shelters, or the infection rate, which is high, and also the food supply. You will see a lot of children with wasted, stunted, and undernutrition. We used to see kwashiorkor and marasmus in 2010. We managed that kwashiorkor marasmus very highly, and we are expecting the same in these times. Again, early identification is really important because a kwashiorkor is usually a serious life-threatening illness for children younger than 2 years of age. There are a lot of supplies, food supply, which is available. This is called ready-to-use formula. It's just a peanut butter or cocoa butter paste available, which give 75 kilocalories or 100 kilocalories per kg per day. Again, if this is not available, then F75 and F100 formula can be used for managing malnutrition in these areas. As we know, this is important to know that asthma with or without exacerbation is prevalent in the community. So in these areas, when we do for medical camps or we go for calamity things, we usually take the inhalers with us, because at that time, nebulization, you really need electricity, you need access, and you need saline. So according to GME guideline, you need to take short-acting beta-2 agonist, which is either salbutamol or albuterol. And then you need to take long beta-2 agonist along with the inhaled steroid that can be available in the form of Zaltide for younger children and Seretide for older children. Steroid is really important to be in your box and treat as per as needed. Anti-allergy and also controller medicine, because you may not be going there again. So you need to have this good supply of montelukast and ketotifen if you identify a child with suspected asthma. Because there are no shelters, because there are lack of supply of tents, and post-monsoon season always lead up. Post-monsoon season, it's always more humid, and in this more humid times, the sun actually causes a lot of trouble to younger children and older children. So we used to see a lot of heat strokes. The consideration again is we need to make them hydration. So again, hydration by oral means or by intravenous means is extremely important. If we have not identified early, the chances of survival are minimal or less. The complication risks are really high. So again, we should not leave this risk. Skin manifestation, it's happened in these areas because of the dampened water supply, because the children has no other option, that the land is lacking. So they develop impetigo, which is a staph infection or strep infection on the skin, pustulosis, insect bites, fungal infection, and again scabies, because it's across human contamination. Do not forget that not all the rashes are bacterial. There are a lot of viral exanthems, and a lot of times the measles outbreak or chickenpox outbreak or dengue outbreak happen in these areas, and the first sign is usually the viral exanthem. Do not forget that children are not young adults. They have an increased risk of stress. They have mental stress. The adults are in mental stress, so they can be at the risk of physical violence because they are displaced. So nobody knows where they are living. There is a high risk of sexual abuse in these areas. Again, I'm not saying it's going to happen. Again, nothing going to happen. Nothing going to tell you that's going to happen. So there's increased risk of abuse for beggary and others. Again, how you come to know as a physician, it's examine the child. So anytime a child comes to us, it's an opportunity that we should not miss that clinical examination, because that may be the only clue to get to understand about this physical violence or mental abuse or sexual abuse. Anytime you come to know, it's just important to report it. Things we haven't considered is really important is that there is lack of early child development in these areas, because the schools are gone, because the teachers are gone, because they do not have their normal land to live on. They are out of those education years which are supposed to be. Something which we always consider is really important for any of the country is disability adjusted life years. is going to happen in these areas. They are being through with the asset loss, they have been through, the children being through with the parent loss, and then it's contributing to their mental illness. Lastly but not least, it has to be focused on the entire child as one of the important member of the community. So in summary, the current disaster is worst of all time. Children are vulnerable to serious infectious diseases and non-infectious diseases. They are also vulnerable for malnutrition, poor immunization, and delay in care may pose a serious risk, not only for the health, but also for the life and the cognition of these younger individuals in the community. With this, I would like to thank you, and over to you, Naseem.
Thank you very much, Ali.
Thank you. Thank you, Ali. Lots of important points actually that have come up from your presentation. So I think really important to understand that you talk about vulnerable adults, but also how children could be sort of affected, not only by sort of the medical conditions that you've listed in quite detail and great depth, but also some of the conditions that you may not normally kind of actually look out for during your normal sort of day-to-day routine, but also how vulnerable the children could be during these periods of crises amongst sort of anything else, but also the fact that the children could actually have emotional stress and any other stress, just like adults. So I think some really important points that you've highlighted there, and I'm sure that the audience would take this, all these into account. I'm sure there'll be questions coming up later, and I may have some questions later on for you, but without actually delaying things, I would like to invite Dr. Salma Azam, who is actually a medical trainee at Southport Hospital, and who has volunteered to present an interesting case to all of us. So Dr. Salma Azam, over to you.
Hi, hope everybody can hear me.
Yes. Mm-hmm.
Hi, my name is Salma. I'm one of the trainee in Southport Hospital. I'm not sure if you can see me. Oh,
yeah,
I think
I can see you now. Yes, thank you. Do you want to share your slides, or are you going to?
Oh, yeah. I'm just going to share my slide. Hopefully, I would be able to. Let me know if you can see it. Can you see the slides now?
Not yet. Probably just give a few more seconds. I think we're beginning to. You're about to share your screen now.
Yeah.
Can you see now?
It says yes, we can.
Yes, we can. Thank you. We can. Over to you now. Thank you.
Hi. So my name is Salma. So it's one of the interesting cases which I have encountered when I was working in a Preston hospital. So it's a case which I'm going to tell later about it. So there was a 39-year-old gentleman who presented to us in a GP assessment unit with a widespread rash for the last 2 days. His presenting symptoms were like he has a history of a flu for the last 2 weeks, and he started developing a fever with sore eyes, red eyes, sore throat. And then after 3 days, he started noticing some kind of a rash on his chest because of his eyes and sore throat. And he went to see the ophthalmologist, and who diagnosed him with viral conjunctivitis and gave him some eye drops for that. So he start noticing that rash start spreading to his torso, and start noticing some dysuria, some cough with red and brown sputums. So he presented to us with a septic kind of a picture. He has no significant background. He was not on any medications. The only medications he took in the last 2 weeks was some cough syrup, some paracetamol for the pain, for the fever, and some ibuprofen for the pain. Wife and daughter, they both have the flu-like symptoms, but they were not developing or showing any signs as this gentleman was showing. They recently traveled to Spain 1 month ago and USA on some holidays. So on assessment, his heart, he was quite tachycardic to us. Hemodynamically, he's not very bad. His blood pressure was stable. He was packing temps of around 39 to 40. He was maintaining his SATs on room air. His respiratory rate was fine, and his blood sugars were also fine with us. Sorry. So we did some bloods on him, which shows his neutrophils was a bit high. CRPs was very, very high. Adjusted calcium, phosphate, creatinine, EGFR, sodium, potassium, rest of the everything is fine, apart from slightly raised ALT. Eosinophils, INR, all within the normal limits. So when we examine him, he generally appeared very unwell and very septic. His pulse was regular. His heart sound was normal. He doesn't have any edema. His chest was clear. Abdomen was soft, non-tender. Eyes on examination showed bilateral conjunctivitis. So on examination of his torso, we see a widespread papular rash with indurated patches and scattered pustules on it. Lungs were pretty clear on X-ray. There was some pleural thickening at the left costophrenic recess, and the cardiomediastinal contour, everything was normal. There was no gas or no pneumothorax. We planned to take the septic screen. We took some blood culture. We took some urine cultures. We gave him a very broad spectrum meropenem, and we also gave him some antiviral acyclovir fluid, some eye drops. We took the swab to rule out an infection. We also sent the urine for Legionella pneumococcal in view of the recent travel, did the chest x-ray, admitted him, and asked for a dermatology review in the morning. So next morning, he started getting worse. He developed some mucosal involvement. Some eyes are getting, ocular involvement start getting worse. His lesions have spread into the bullous form, and he developed a widespread erythematous multiforme rash. So he's been seen by the dermatology, and they made a diagnosis of a Stevens-Johnson syndrome. It's a very, very rare condition. 1 in 1,000 people get this. So what we did is we catheterized this patient straight away to monitor his input and output monitoring. Straight away asked for the ophthalmology review, who basically did the amniotic membrane grafting, the schedule on this guy. He became unwell within a day, and then he's been transferred to ITU for that. And then he developed TENS after SJS. So if we talk about Stevens-Johnson and TEN, they basically severe mucocutaneous reaction, usually caused by any of the drugs, characterized by blistering, characterized by extensive necrosis and the detachment of the epidermis membrane. And it affected in 90% of the patients are usually affected by any of the drug. And in 90% of the patient, there must be usually 2 or 3 mucosal involvement. So incidence of SJ is approximately, as I said earlier, 1 or 2 cases per million per year. And the mortality with SJs is only less than 10%, but the figure rise to 30% when the patient turned into a 10. Overall, their mortality is around 22%. How they usually present, so they have the prodrome of the SJS or 10 is like they have a fever-like symptoms with headache, some malaise, and upper respiratory tract infection kind of a symptoms. And then they might have an ocular involvement that may develop later or earlier before the skin starts slugging off. Cutaneous pain is the most prominent feature of the SJS and TEN that's basically differentiate from other kind of a disease like erythema multiforme or Dressler syndromes and all. So how we check about the skin fragility? So these patients, they develop the skin lesions. They are ill-defined, they collapse, they become erythematous, macular with purpuric centers. And these lesions, I said earlier, like in this patient, started on the face and then thorax. They typically spare the scalp, but they spread very symmetrically and oftenly involve the palms and the soles. Nicholson sign and the bullous spread sign is the main sign. We can look on these patients to find out how much the skin is getting damaged. Then these skin, as you start spread, detaching, and from the sheet of the epidermis, it become denuded dermis, and that start exuding the serums, become vulnerable to secondary infections, and really bleeds. Involvement of the mucous membrane of the eye, mouth, nose, and genital is also very, very common and seen in these patients. If there is an ocular involvement, the patient may have a conjunctivitis, they have a purulent discharge from it, they suffer from the photophobia. And those people who genitourinary involvement we've seen, then they suffer from urethritis, they may develop urinary retention, then erosive and ulcerative vaginitis is very, very common in the females. In these patients, we also see the hematological abnormalities. If we do the blood films, we can see they might have an anemia, lymphopenia. Eosinophilia is very unusual, and if they start becoming neutropenic, that is basically correlate with the poor prognosis of these patients. So what is the common? So drugs are the most common cause of SGS and TAN, apart from some viruses. And the most common drugs are allopurinol and some carbamazepine, lamotrigine, NSAIDs, some sulfonamide antimicrobial drugs. These are the most common drugs that can cause SGS. Any drug that has been started in the first 8 weeks might be the culprit behind the SJS. So for any patient who come in with any new use of a drug, we straight away stop it. Like in this gentleman, the only medication he has taken is ibuprofen. It is very, very common to get it missed when we are asking the patient history or look at the drugs. Most of the time, we missed it. Has he taken any over-the-counter drugs? And so ibuprofen is a very common drug that people usually take for the pains. As I said earlier, few infections like Mycoplasma pneumoniae infection, it is also one of the other major cause of SGS, but it's mostly common in children. Other than that, few viruses like HSV, HIV, influenza, they can cause SGS. And in over 1/3 of the cases, we can't find any identifiable source that have causes it. And again, some systemic diseases can cause it. And there are few cases where the patient have a bone marrow transplantation and then they develop the SGS. So if we look at the phenotype, so we have to divide the SGS into two on the basis of body surface area. If it's less than 10% involved, it is SGS. But if it's more than 30% involved, then it's called TAN. And then there is an intermediate term we use, SGS and TAN syndrome, that overlap between these two when the body surface area is between 10 to 30%. So how can we know that how severe is the condition is? We use the term score 10. And then we have few factors on it. So looking at the age of the patient, anyone who is above the age of 40 are more susceptible of having a poor prognosis if they develop SGS or TAN. Malignancies, body surface area, are they tachycardic, serum urea of greater than 10, and any patient whose blood shows serum urea of greater than 10 and serum glucose of greater than 15, they have a very poor prognosis. 30 to 40% patient who have these blood picture died after having the SGS. So what are the basic complication of this? Infection and sepsis is one of the major complication patient can develop. So sepsis in the form of the bacteria. So two major bacteria is Pseudomonas aeruginosa and Staphylococcus aureus. A majority of the patients' blood culture shows these two organisms they are growing because their body is badly slugging. So obviously they are exposed to a lot of infections. So they have sepsis is one of the most common cause of death in these patients. Then obviously because their whole skin is slugging, so they are very susceptible to having dehydration and electrolyte abnormalities. And as I said earlier, these are the prognosis of very poor outcome for these patients. Ocular involvement is also one of the major mucosal involvement we see in patient. Even if the patient have not a very severe SGS or 10, they have a very, they might have an ocular involvement that is not very evident at that point, and it's lead to a very bad long-term sequelae for the patients. So how we are going to treat it, because there is no diagnostic, it's neither diagnostic nor it's difficult to diagnose. There is no histological finding for this SJS. Even when they take the sample from the fluids, they can't find it for what exactly is causing the SJS. Either many patients, either they have some drug reaction to it, or their phenotype is like this, that they are more prone to, like many Asian population, if they are started on carbamazepine, they may develop SJS. So when it's come to the Asian population, and doctors are very, very careful in starting the carbamazepine. They always try to find out the genotype of this patient. Are they susceptible to SJS or not? So how we are going to treat these patients? Supportive measures are the mainstay of treatment for these patients. So we try to manage strong evidence, and like we try to give these patients some fluids and electrolyte management. Nutritional management is also something that we have to look into it. Temperature management, pain control, infection prevention and management. So fluid and electrolytes, we have to make sure that the patient are getting enough fluids into the body. We should try to give approximately 1/3 lower than those for the burn victims. In most of the countries, these patients are treated in the burn unit, but here in UK, like we have some pressures area rooms where we treat SJS patients. So fluid replacement, as I said, is very, very essential to prevent the end organ damage because of the hyperperfusion and shock, because these patients are losing a lot of fluids because of the skin deslugging. There should be an ambient room temperature between 28 to 32 degrees for these patients. Because if the temperature is up and dry, there is a high calorie expenditures, and there would be a more epidermal loss for this patient. Prevention of infection is also very important. As I said earlier, 30 to 50% of the patient, they develop bacteremia, and sepsis is the most common cause of death in these patients. Reverse wearing nurses in an isolated room is also very, very important. Sterile handling. These patients should have a repeat blood culture in every 48 to 72 hours from, from all the lines, from gastric lines, from urinary tubes, or look for any sign of sepsis. So they don't have a typical picture of the sepsis. These patients, like the sign of bacteremia, including these patients, are hypothermia, confusion, hypotension, and decreased urine output. Those patients who have hypothermia with elevated prolactin levels at time of the blood culture show that they are growing something in their blood culture. Antibiotics should not be given until there is a evident source of infection on these patients. Urogenital involvement is occur in 70% of the patient because of the erosive of the urogenital area, and they develop sepsis, urinary retention. So it is recommended that urogenital and gynecological examination should be a part of the baseline assessment for these patients. Non-adhesive dressing is recommended for these patients in urogenital area with potent topical steroid. And for the females, it's recommended that we should apply some estrogen cream to help in reepithelialization. Silicone vaginal dilators can be used to prevent the strictures and adhesions. And in reproductive age females, it's recommended to suppress the menstruation cycles during that time to prevent and to help in reepithelialization of the skin. As I said, ocular involvement is very, very common, and it can lead to very, very poor prognosis. So eye care is very important. 2-hourly lubricant should be used with the gently separating it to prevent the syncytial and the corneal scarring. Mucositis, stomatitis is also very common. So antiseptic mouthwash with oral sponges is also recommended for this patient. Pain is something, as I said, that is the typical feature of a 10. So they suffer from a very bad pain. So it is recommended that we should ask this patient every 4 hourly, ask about what their pain score is. If it's about 1 to 4, we should give him some paracetamol, offer some paracetamol. But if more than that, then we should offer him some opiate through intravenous injections. Again, as I said, these, because they are going to be nursed in the bed for a longer period of a time, DVT prophylaxis should be given to these patients. If we talk about the complication, as I had talked earlier, so these are the complications which I have explained earlier, can be happening in ocular dehydration, electrolyte imbalance, can be given dermal emollient sprays, IV fluids. If any infection of the eyes is developing, we can give him some broad spectrum antibiotic, paracetamol, codeine. So patients who have ocular involvement, they can be offered amniotic membrane transplants. It can provide a new basement membrane to the patients. We usually give amniotic membrane transplant to the patient who have extensive slugging of the bulbar conjunctiva, and they have started forming the pseudomembrane on top of it. So these are the patients who can have, who will benefit from the amniotic membrane transplantation. It preventing the anti-scarring action, anti-angiogenic actions, anti-inflammatory actions. So long-term sequelae of these patients is like they suffer from the cutaneous hyperpigmentations, deformed nails, mucosal involvement, like suffer from stomatitis or burning sensation, or they might have colonic perforation, or all these kind of a thing. They usually suffer from ocular involvement, as I said, ingrown eyelashes and scarring, conjunctivitis, photophobia. Pulmonary complication is also something that we should have to look for, because these patients can develop ARDS in their acute phase, and in the long term, they can develop some interstitial changes. Obviously, those patients who have this SJS and 10, they're psychologically, they are very, very disturbed. So they need some psychological support and psychiatrists and well-being support throughout this journey. Patients should be educated about the agent that has caused this in the form of a drug. We should be giving some bracelet. We should be updating their record of the patient so that we can prevent reoccurrence of it, because reoccurrence.
1 minute.
Sorry?
1 minute.
Yeah.
No, I'm saying you have 1 more minute. So.
Oh, 1 moment. Okay. So regular dermatology review is very, very important. This patient, and dietitian input is also important. So this is one of the studies that show that like how the recurrence of these patients as one recurrence only shown by microcosmic associated SJS. And these are the few differential diagnoses. These are the things that patient can come, and we have to differentiate between is it SJS or is it erythromaldiform or Staphylococcus aureus skin syndrome or other thing like that. Thank you.
Thank you very much, Salma. That was a really interesting case. Out of interest, just wanted to kind of actually ask you, what was the outcome for your patient?
Yeah, so the outcome with my patient is that fortunately he survived. He's been cared in the HTU, but he became very, very unwell. He developed tan, but he fortunately survived. So, but we gave him all this education to not to take NSAID lifelong. And I think that poor gentleman has only taken 1 or 2 doses of the NSAID, and he ended up in the hospital with this.
Yeah, it is so sad that actually just 1 or 2 doses, and unfortunate that it actually had to go through all of this. And also just as a reminder that how common and often NSAIDs are prescribed by all of us.
Yeah.
Maybe not by me, because being a nephrologist, I really like to actually avoid NSAIDs, but I think prescribed by physicians in general. And then we never kind of actually educate or kind of warn our patients about such a disastrous complication, which, as you said, is quite rare, 1 or 2 million per cases. 1 or 2 cases per million, actually. So yes. But thank you very much. That was a very informative session in terms of actually going through the Stevens-Johnson syndrome, talking to us about the differentials. Maybe one more question about how quick did you get a dermatology to come and review your patient? We struggle with a dermatology in patient reviews. I don't know how easy was it for you and your colleagues?
Yeah, so in this case, it's very difficult. I remember there is one more patient I was suspecting that he might have an SGS as well, but he didn't have any mucosal involvement. And my consultant asked me to ask for a dermatology, and I rang around every hospital. I couldn't find any dermatology. In this case, we got to know about. We asked the dermatology, and when we told them there is a mucosal involvement going on, so they straight away came to see him in the Preston. But I know in the Southport, it's very difficult to get hold of the dermatologist. But
Yeah,
any patient who get involved with the ITU, I think then they can push for the dermatology earlier review.
we had similar sort of actually difficulty in getting some of the erythroderma crisis and Stevens-Johnson syndrome are the two really kind of actually crises that we ask dermatologists to come and review and give their input. So it's a shame if they don't sometimes, just because the nature of the job and the clinics usually keep them occupied. But thank you very much. That was really helpful to go through that. Really well presented. And yes, I'm sure that we can actually invite you again to present an interesting case in the future. Dr. Ali Faisal has got a question. Ali, yes.
Thank you, Mansoor, and great presentation, Salma. I think one thing which I just want to mention about the consideration of having the dermatology availability in the developing countries, right? So remember, like in countries where we don't have that type of luxury or a secondary care facility, where you have a lot of antibiotic use in the community, and when these anti-epileptic drugs are more in the community, the chances of having SJS is more. I remember like I used to see 4 or 5 patients every year in my hospital. And here in most of the times, we managed to be able to manage the children by ourselves. There are new options available for particularly like laser therapy for their eyes. So the early you do, the early they have the better outcomes. So I think you just why don't you just talk about the few new things like using monoclonal antibodies use or systemic corticosteroid like methylprednisolone or IVIG use. I know that you have mentioned that IVIG use is controversial, but in situation where there are lack of things, I think this is one of the better way to go about it. Over to you. Thanks.
Yeah, so I think what they say that the cyclosporin, they use this one. They don't recommend steroids because the only time they recommend using the steroid is when the patient is very badly neutropenic, and then the demarginalization of the neutrophils can help in these patients. But other than that, the studies have shown that there is no benefit of. They can give any patient, even the only neutropenic patient, they can give him GCSF to help in the septic condition. But what I have read and what the dermatologist told me, that there is no role of steroids in these patients. They might only suppress the immune system of the patient, like any patients who have any background of malignancy. Like but in Pakistan, there is no treatment for the cancerous patient. But here, many patients we ended up seeing the patient like 1 or 2 in 5 patients has got some background of a malignancy. So these patients, we have to be very careful in giving all these kind of a medication like steroids and all.
And also you've got to bear in mind, basically, because if you've got an unwell septic patient who's actually immunocompromised, then I think throwing cyclosporin and high-dose steroids would actually further worsen the sort of the sepsis or the infections. You've got to really kind of actually have that balance between, giving something, throwing something to a septically unwell patient. I think Dr. Ali Faisal question was more about immunoglobulins. And Ali, I think I have actually once seen immunoglobulins given in a particular patient that I've actually looked after as a junior doctor many years ago. But yes, I think the role of immunoglobulins, if I'm not wrong, Salma, just correct me, it's controversial as well, isn't it?
Yeah. So it's again the mixed studies. Some say that you can give it, and some say that you cannot. But they have given into the few patients just as a trial. So it's just a risk versus benefit at
Okay.
that time.
Lee has got a question or his hands are raised. Yeah.
So for the IVIG, I think the role is giving early. So the earlier you recognize, the better to give. If you are giving in the middle and later part of the disease when the excoriation happen or the Nikolsky sign appear more stronger, the risk of having IVIG or trolley, because I remember like in one of my child who received IVIG, later part of this developed trolley, which is transfusion related acute lung injury. So I would say that giving this IVIG early, we able to save more children compared to adults. I really don't know about the adult studies, but I know as a pediatrician that all those children who received this IVIG early part of the disease, they recover as good as compared to children who haven't received this IVIG early part of the disease. Over.
Okay, thank you. That's really helpful point to know, and note maybe further discussion with your pediatrician, Salma. If you've got some in the department. But thank you very much. Ali, just whilst we're on this topic, I know we need to actually finish and wrap up soon. But I just wondered whether you've got any sort of comments on the question posed, or maybe I've actually written that in the comments box about hypothermia and rhabdomyolysis in children. Would it affect actually children as much as it would affect adults during any natural disaster, especially the hypothermia during the recent floodings in Pakistan? Thank you.
Thank you, Mansoor. I think there are two more concepts you have asked about. One is the hypothermia, and I would say it's a calamity effect, right? So Pakistan and the Asian population is not, particularly in this type, the temperature is really high. So they are actually having more of a hypothermia, like heat stroke. And then rhabdomyolysis as well. So one of the way to identify somebody with heat stroke is to check their CPK level and others and see if they have more muscle mass derangement happen. However, hypothermia used to happen in younger and the newborns. So remember, like the day before yesterday, there was a baby who was born in that tent. 1.9 kilos, 32 weeker. So remember, like these children used to have hypothermia, hypoglycemia, and both are actually signs of sepsis, right? And signs of mortality. So again, yes, very important to know that if there's going to be hypothermia in younger children, and once it develops, it has to be acted quickly and it has to be corrected.
Excellent. Thank you very much. Thanks for the detailed explanation there. I think we'll come to a close of this session. It has been an informative session, and certainly I've actually learned a lot from Dr. Ali Salim's presentation about management of younger children or vulnerable children during such emergencies and crises, and also from that interesting case that Dr. Salma Azam has presented. Professor Naseem Naqvi, have you got anything else to say before we wrap up?
No, I think excellent presentations. Thank you to both speakers, and we will meet up again next month.
Yeah, so we've got another interesting session of a lineup of presenters actually in the next few months. So we've got one in October, 16th of October, that's the next date. So who are the attendees, please actually mark that date in your diary. And then we've got another presentation in November. We will have a break in December, but resume our activities in January. So we've got 2 more presentations in the next few months, and all the very best. Thank you very much, and we'll see you soon. Take care.
Thank you.